Before we finish, I just want to make an important point that when you're treating hyponatremia, particularly if it is chronic hyponatremia, you want to ensure that you don't correct the sodium too quickly, because this increases the risk of pontine osmotic demyelination syndrome. Now, to understand osmotic demyelination syndrome, we can look at this basic diagram here, where in blue we have a representation of a neuron, and in red here we have a representation of the adjacent blood supply. When the serum sodium concentration is relatively normal, there are no significant osmotic shifts of water from the intracellular space to the extracellular space. And so the neurons remain healthy and of a normal size. In hyponatremia, because there's a reduced sodium concentration in the extracellular space, there becomes a tendency for the water to go inwards towards the cells with this sodium gradient, which can lead to swelling of the neuron. However, prompt treatment of the hyponatremia will reverse this process and the neuron will return back to its normal size without significant permanent damage. But coming back to the hyponatremic state, if this hyponatremia is chronic, the neurons will need a way to prevent the water from being drawn into the cells, which would cause the neurons to swell. The adaptive mechanism that is employed is that the neurons produce osmolytes, which are then secreted into the extracellular space, into the bloodstream. These osmolytes effectively make up for the lack of sodium in the hyponatremic state, and is therefore able to maintain the osmolality in the blood, which prevents the water from being drawn into the cells. However, when hyponatremia is rapidly corrected, the osmolality of the blood rapidly increases, which therefore leads to the water now being drawn from within the neurons out into the blood. This can lead to severe desiccation of the neuron, particularly in the pontine region, which is particularly sensitive to this. And this neuronal desiccation is much more detrimental than neuronal swelling, which can then cause permanent neuron damage. Damage to the pontine tracts can then lead to things like motor weakness, which can be very severe and debilitating, not dissimilar from a central pontine stroke, which may present like a locked-in syndrome. The risk of this happening is highest in patients who have had chronic hyponatremia because they've had time to produce these osmolytes. In contrast, in acute hyponatremia, because of the absence of the osmolytes, there's very little risk of pontine osmotic demyelination syndrome. But practically, it's very hard to tell whether a patient has truly acute or chronic hyponatremia because most patients don't have blood tests very frequently, and the reported symptoms may not be reliable, and patients may be asymptomatic when they are hyponatremic. And so we generally consider all patients with hyponatremia to be at risk of pontine osmotic demyelination syndrome. In order to prevent this, we must ensure that we slowly correct the sodium, aiming for less than 9 millimoles per liter of correction per day. This will allow time for the neurons to reduce their production of osmolytes and minimize the severity of any osmotic shifts in fluid. In general, fluid restriction alone does not cause pontine osmotic demyelination because patients are unlikely to excrete too much free water in the setting of reduced RAAS activation from fluid restriction. Once the intravascular volume and sodium concentration is restored, there will no longer be a stimulus for ongoing free water excretion, and the renin-angiotensin-aldosterone system will take over and continue to regulate intravascular volume and maintain a normal sodium concentration. In contrast, active replacement of sodium, particularly with hypertonic saline, poses a significant risk of osmotic demyelination, which is why this is usually done in a closely monitored environment. And now I want to summarize and put everything together with an approach to hyponatremia. Like everything with medicine, it all starts with a good history and exam, where there are often clues in the history that can tell you the cause of the hyponatremia, such as new medications that have been started, whether the patient has significant GI losses, and whether the patient has significant past medical histories that will put them at risk of hyponatremia. A good clinical examination to determine the patient's volume status is required, because this will be able to tell you which of the 3 subtypes of hyponatremia the patient may have. However, practically, it can be difficult to distinguish hypovolemic hyponatremia and euvolemic hyponatremia, and so patients are usually investigated for causes of both of these subtypes. But before you launch the investigations for hyponatremia, you want to make sure that it is not a osmotic hyponatremia by correcting the sodium level for glucose, particularly if it is very elevated. A normal corrected sodium means that the hyponatremia can be attributed to the osmotic effect of glucose, and hence no further investigation and treatment is required. Next, you want to check the osmolality of the serum to make sure that the patient has a true hypoosmolar hyponatremia, because a normal osmolality may suggest a pseudohyponatremia from excess lipids or proteins in the blood. You can then further investigate the hyponatremia if it is a true hypoosmolar hyponatremia using a urine osmolality, which reflects ADH activity, a urine sodium, which reflects renin-angiotensin-aldosterone system activity, and a urine potassium to calculate the urine to serum cation ratio, along with an EUC to check the renal function and the sodium levels and other electrolytes. If the hyponatremia is severe and symptomatic, it should be corrected, usually with hypertonic saline, in a monitored environment. And you should avoid rapid sodium correction to prevent osmotic demyelination syndrome, usually less than 9 millimoles per liter per day, which is particularly important in the setting of chronic hyponatremia. You want to investigate for specific causes of hyponatremia based on the subtype of hypoosmolar hyponatremia, and ultimately you want to target your treatment to treat the underlying cause, along with treatment of the subtype of hyponatremia based on the underlying pathophysiological mechanism. And that brings us to the end of this video. I hope you now have a better understanding of hyponatremia in terms of the underlying pathophysiology and the clinical application. This approach to hyponatremia slide summarizes the key points that we've discussed throughout this video for your review. If you like this content, please leave a like, comment, and subscribe to the channel. All the best.